I am really privileged here to be with my good friend and colleague, Dr. Thanos Dimopoulos, who I think many of you know quite well, a true giant in our field, and one individual who has made so many contributions to the drug therapy of Waldenstrom's macroglobulinemia, way even predating me, and really giving me the opportunity to have learned so much from him and through our mutual interactions over the years. Thanos was also the co-organizer for the second international workshop on Waldenstrom's. I already told you about the first one with the coffee maker not working. Well, by the time we had the second one, we had plenty of coffee and we had plenty of data coming in. But what was really memorable about that workshop that happened in Athens was it was the first time that we were able to come together in consensus and agree on the basic elements of Waldenstrom. We did not even have a pathological definition for the disease. And so thanks to Thanos and Bob Kyle, who was there, we were able to organize a phenomenal second workshop. And we had a definition, we had criteria to when to treat Waldenstrom's, because up to that time, people were being treated right off the bat. In fact, many people looked at the disease as multiple myeloma and just would start therapy. And then we also were able to get our first treatment guidelines together, at least addressing some of the early drugs that were available. And so what was really important about that is we were starting to think about Waldenstrom's as its own distinct entity and pulling it away from all these other diseases where things were being confused with and people were being, in many cases, overtreated, even being offered transplants right off the bat because everybody thought, well, this is like myeloma, might as well treat it. And I think also this is where we had our first official response criteria that we put together. And this was, I think, extremely important because it gave us a common language, because you can see people doing trials, but if one person's using one set of criteria, another person's using another, you really can't compare things. You're getting really different definitions. And this was all, in great testimony to the leadership and expertise and experience that Thanos brought at that wonderful meeting in Athens, Greece. So I do want to have him stand and be acknowledged by all of us for all his hard work and efforts for Waldenstrom's. And today at this session, we're actually going to hear about ibrutinib, and I'm hoping that many of you have heard about this drug. And we'll be updating you on some of the key trials. I'm actually going to start off and focus my comments on the use of ibrutinib as a single agent. We refer to that as monotherapy. So in case you see the slide that says monotherapy, that's what it means. And Thanos is then going to talk about a trial of ibrutinib, again, as monotherapy in a select patient population that, had exhausted Rituxan as a option. And then he'll talk about the very exciting INNOVATE-AB trial, which is a trial that, he'll tell you about, which is ibrutinib combined with rituximab, and you'll hear some very exciting data. I think the thing to get most fired up about when you look at the references, because every one of these slides has references, 3 New England Journal of Medicine papers, okay? You get one of these in your lifetime and you've had a home run, but you think about 3, dedicated to Waldenstrom's that propelled, all the progress. And this past week, we also had, a paper in the Journal of Clinical Oncology, and that's really our top journal in oncology. And so when you look at this work, think about it in the context of where it's being published. And when you see these kind of high-value journals publishing this work, we all should get proud. This means a lot to all of us because it really shows it's genuine progress. And to be there in the big journals is kind of fun. It's really exciting. That means people are paying attention too, so that's what's great. All right, so let me start off with my presentation. And am I supposed to just push a button here? Because I want to make sure. Are you guys driving it there, or am I driving it here? Okay, well, we solved it here. I can see it, but can we get it on the screen for the rest? Doug? Oh, wow, yay. All right, ibrutinib monotherapy, so single agent therapy. So these are all the individuals that played a role in this study. And what I want to just say right off the bat is this was an investigator-sponsored study, which meant that the company supported it, but it was actually run by the investigators. And I just want to show you here our disclosures in terms of support that I've received, from various pharmaceutical companies in support of this and other work. Okay, I always love showing this slide because it really speaks to the state of affairs that we had for Waldenstrom's. We had basically a hand-me-down approach to treatment. We would, go to all our different colleagues in myeloma world, lymphoma world, CLL world, any world we could go and borrow drugs from to test. And this clearly, put us at a major disadvantage. And along came, our ability to start innovating in Waldenstrom's. And it started with the discovery of the MYD88 mutation. Now, I want to show you this. I know these are a little bit of a deep dive, but I want to show you this because this extraordinary investigator, Dr. Yang, made a very interesting discovery in our laboratory. And what he showed was that mutated MYD88 actually bound to BTK. This is the target of ibrutinib. And he found this only occurred in those MYD88 mutated cells. And these are the blots. What they do here is kind of clever. They use antibodies that bind to proteins, and they pull these out of the cells. And then they stain for that. And then they stain for proteins that they think might be bound to that particular protein. So in this case, he's trying to figure out, he's fishing for what's bound to MYD88. And what he found here was he found actually the activated form of BTK, the target of ibrutinib. And that's why he got all fired up and decided to then start screening cell lines. These are cells that are growing in culture. And he started screening to see whether or not they were sensitive to ibrutinib. And what he showed was that these Waldenstrom cells that had the MYD88 mutation were very, very sensitive to ibrutinib when he did these test tube studies. And so he then began to work very hard, and this is the signaling diagram that he was able to create. This is a very complex diagram, but I'm going to tell you, we need not make any apologies for its complication because none of this was known even just a few years ago. We had no diagram to tell us what's actually going on with MYD88. And he created all this work, and it resulted in two very important publications. And so what did he teach us? Well, what he taught us is that MYD88 itself is a very pivotal protein for the immune system. And usually various particles, viruses outside of the cell come in contact with these things called receptors. Receptors are like satellite dishes that are out there waiting to pick up signals. And this signal here, the toll receptors, senses for infectious particles, pieces of bacteria or viruses. They usually come in contact and then they signal through MYD88. But if you have the mutation for MYD88, it's like the switch gets turned on, but it's broken in the on position. You no longer need the satellite dish to be communicating things. What you see is that the internal switch gets broken and it's turned on, and as a result, this MYD88 mutated protein is firing away signals all the way down its pathway that turns on this molecule, NF-kappa B. And this is a critical signal that makes the cell want to grow and survive. And at the root of this signaling is here, BTK, which is, of course, the target of ibrutinib as well as other BTK inhibitors. We're going to focus today, at least in this session, on ibrutinib, but just know that there are other drugs that can also shut down BTK. And one of the things that was made also as part of the discovery was that there's an inhibitor to BTK called iBTK that's missing in a lot of patients with Waldenstrom's. Their cells don't have it. So not only have you turned on BTK, but the protein that's there to actually dampen it or slow it down also got lost. So it's like one foot's on the accelerator, but the brake is now broken, and even if you're pressing on it, it doesn't do any good. So you think about that. And then he made another very important discovery that was published 3 years later. I wish 3 days later. It took him 3 years to work on it. And that's he found that this other molecule called HCK was also turned on by the mutated MYD88 protein. And this was a master switch. It turned on all these other pathways that were also very important to keeping the cell alive and growing. And fortuitously, this also was a target of ibrutinib. And so you'll hear people say, well, ibrutinib is a BTK inhibitor. I'm sure all of you have heard that. But it's really being very simplistic. Ibrutinib can actually affect a lot of other kinases, a lot of other enzymes that are very important for the growth and survival of the Waldenstrom cells, among which is HCK. And this is how we can start distinguishing these various inhibitors of BTK, because some of them have a little more activity, maybe because they can suppress these other kinase targets. Now, we're going to hear a little bit about CXCR4 in just a second, but I also want to show you sometimes this basic work, because it makes us all think about, how these concepts get born. And we owe tremendous amount of, gratitude to Yang Kao, who had published several papers after CXCR4 was discovered. And what she was able to do is to teach us a couple of things. She created all these CXCR4 mutated versions, and she put them into cells, and then she started studying them. And I just want to show you here this very interesting diagram. This is cells with ibrutinib added on. These are the cells without the CXCR4 mutation. These all have various CXCR4 mutations. And you can see that you can induce these cells to die. You see this second spike that just comes out of nowhere? That cell's dying, and you see that this actually is occurring across the board here, right? All these cells, whether they have no CXCR4 mutation or they do, they start dying. Now you add in, the growth factor for CXCR4, and what do you see here? Well, the ones that don't have the CXCR4 mutation continue to die. Those that have the CXCR4 mutations that she created, you see decrease in cell death. And so this began to make us think that maybe when we ultimately look at the activity of the ibrutinib drug, we might see differences based on what somebody's underlying genomics is. So I'm going to start off first by talking about the Frontline study. This is the one that just got published. It was actually the editor's pick, by the way, in the Journal of Clinical Oncology. I think we can all be proud of that we got highlighted. And I just want to acknowledge Jorge Castillo, as well as our nurse practitioner, Nurse Practitioner Dubois, and our CRCs, our clinical research coordinators who made this study possible. And what I want to do is, let me just get to the meat of this. The meat here is that these were patients, 30 of them on this study, who actually were pretty sick. I mean, the average IgM was 4,300. The average hemoglobin was about 10, so these people were really anemic. And their bone marrow burden on average was 65%, so 2/3 of the bone marrow was replaced by Waldenstrom's. These were, again, patients that never had been treated previously, so they were seeing the ibrutinib for the first time. And these are the results. Overall response rate, 100%. Everyone responded. 83% had what we call a major response, or at least a 50% reduction in their disease burden. And more importantly, when you looked at the time it took to get a response, to a minor response, it was basically 1 month. To a major response, again, 50% reduction in disease burden, it was just shy of 2 months. But there were differences depending on what the mutation status was. These were all patients that had the MYD88 mutation. And if we look then to see how they did based on their CXCR4, these are the people that are normal for CXCR4. We call them wild type. So if you ever hear me using the word wild type, it means normal. It's what you see in the wild. And here you see mutated. And what you see is there's a difference. Even though everybody responded, those deep responses are fewer in those that are CXCR4 mutated, particularly what we call VGPR. If you heard this term, very good partial response, it means a 90% decrease in their tumor burden. And look here, 31% got there who had no CXCR4 mutation. Only 7% got there if they had a CXCR4 mutation. And more importantly, and this is the point that I want to make, is it took longer. It took 7 months versus just shy of 2 months to get to those deep responses if you had the CXCR4 mutation. And that's really important for us to know, because we get very often the phone calls from our community doctors who say, well, you know what, I gave the ibrutinib, it's now like we're in our 2nd or 3rd month, it ain't working, and I'd like to think, and want to talk about what we should do next. And it's really that concern out of early abandonment that we have, which is why it is nice to have everybody's genotype done up front so you can set expectation. Dr. Demopoulos will talk to you about a way that we're now trying to overcome this limitation with the addition of, rituximab. He'll talk about that shortly. So how long does it take to catch up? Well, it takes over 6 months, and that's what we found, on average, it was about 7 months. We track that because you can see right off the bat that if you have no CXCR4 mutation, these are the people in red, they really pop up, by the time they're back by their 3rd cycle. They're really deep into these major responses, but the ones that have the CXCR4 mutation shown in blue, it's just taking more and more time. One of the big messages out of this trial was it's well tolerated. We had very little toxicity. Overall, patients tolerated it. We did have 2 people with atrial fibrillation. And one of the patients was continued on therapy with medical management, and one needed cardiac ablation, and he had also a predisposition to the atrial fibrillation. Part of his left atrium of his heart was enlarged, and that predisposes you. We can certainly talk more about atrial fibrillation later, but it is something that we do see with this drug, and as I'll show you with further data in just a moment, the vast majority of patients we can continue therapy without stopping the ibrutinib. Now, there was also a very important lesson, and Dr. Castillo has also, expanded on this even further with other work. But if you hold the drug, and many times we have to, because somebody's going to go in for a procedure, you want to hold the drug so you don't put them at risk of any bleeding related to the procedure. What happens is, in a lot of these patients, the IgM then just starts going up, in fact quite rapidly in some patients. So maybe 37% of the patients, as the study showed, could have this bump in their IgM, and also the hemoglobin goes down. And so you can have actually these decreases, and then when you restart the ibrutinib, it may take a while. The IgM to get back to where it was, almost 5 months. The hemoglobin to get back to where it was, almost 4 months on average, even with these holds. And so the bottom line here is avoid drug holds when possible. We don't want these things to be taken casually. And we've also, as doctors, have started to become far more sensitive to this. And the drug holds that we used to recommend, if you're going to have a procedure, hold 1 week before and 1 week after, this was creating more problems. And so you're going to say, well, how do we get around this? Sometimes people need procedures. It's true, especially when you're on a drug, for, an indefinite period of time and you need something done. That's where a very important conversation is needed between your doctor and the surgeon or whoever is going to be managing you for that procedure. But there's also procedures that we don't really need to have those kind of holds. There's minor procedures that, the holds can be a lot less, a few days before, a few days later. Some things like cataract surgery, which really don't result in any bleeding, might not need a hold. But those are the kind of things that, if you're ever going to have a procedure and it will require a drug hold, talk about it. Sometimes we've even talked to our surgeons and said, do you really need to do this open procedure? And then, when you explain to them what's going on, they'll come back and say, you know what, maybe we can do this, as an alternative approach. In the case, we had a patient with a bladder tumor, and, is either going to be an open procedure that would require, a big morbid surgery, or cystoscopy, where they just put in the cystoscope and they snipped it off. And by having the discussion, you're able to modify the behavior of the surgeon and said, you know what, we probably could do it this way. And so it's important if if you are going to have a procedure, have that discussion. And that's why I keep telling people, that's why we still need doctors, to be able to make these decisions, because it really is an art. It's not a science. Okay, what else did we learn in this trial? Well, we learned that at 18 months, 92% of the patients who were on ibrutinib still remained on ibrutinib and were doing well. All the patients were still alive. We did have 2 out of the 30 patients progress, both of whom had the CXCR4 mutation. Keep that in mind because it's a redundant theme. You'll see this again in the trial that I'm about to show you in just a second. So overall, very exciting trial, good responses. The CXCR4 mutation status played a role, and just the lesson around the drug holds. And I just want to show this picture. I'm very proud of just showing all the folks back at home, both in the clinic as well as in the laboratory, that make all this work possible. So now I'm going to just go over the trial, the update that was presented here on the use of ibrutinib in people who have already been treated. This was the pivotal trial that led to the approval of ibrutinib in the United States as well as Europe. And I just want to acknowledge all my collaborators, including Leah Palumba, who's here with us today. Just a round of applause for Leah. One of my heroes. And also Ranjana Advani at Stanford. So this was the, trifecta, as I call it, that made this trial possible. And, the patients, even on the frontline study as well as this one, they got 420 milligrams a day of the ibrutinib. And we basically continued therapy until the patient either, showed evidence of progression or didn't tolerate the drug. And so the update that I'm going to be showing you here today is based on an expansion of time data. So originally when we reported this study in the New England Journal of Medicine, we only had an average about 19 months of follow-up. Now the follow-up is much longer. I'm going to report to you the follow-up as of 47 months. That involved a data cutoff of December of last year. And this will be once again updated because the last patient allowed on this extension study, the data could be collected up to October of 2018. And so we'll be getting even a further update, which I hope will be published sometime early next year. This, too, was a very sick population of patients because you think about it, the average prior therapies was 2. Some patients had up to 9 prior therapies. You think about it, you can just sit here and try to imagine 9 prior therapies basically means every drug that we had available to us. And more importantly, and Thanos has really taught us a lot about this. Anytime I read Thanos' studies, he really makes a point of distinguishing patients who have been previously treated as being either people who have seen prior therapy and then their disease came back, or that they were refractory, meaning the drug they just got before, it didn't work. And that's actually a much sicker and concerning population of patients when they're not responding at all. And 40% of the patients on this study didn't respond to their prior therapy. And you can see hemoglobin average was 10 milligrams per deciliter, average IgM was 3,500, and the average bone marrow involvement was 60%, so pretty impacted. Right off the bat, what you'll see when you look at the IgM levels or the hemoglobin, things improve very fast for almost all patients who get ibrutinib. And in fact, this showed, the original data showed that the average IgM went from 3,500 before therapy to 880. With the update, it went down to 821. These are not really that different. It means that whatever bang for our buck that we got it pretty early. We saw it really with the original study. And when you see the best hemoglobin response, most of the bang for our buck happened early on too. The average hemoglobin went from 10.5 to 13.8. That's a monumental increase, by the way, compared against any of our studies. And, with further follow-up, it was 14.2. So most of the action happens, and it happens, fairly quickly. This is the update on the responses. The overall response rate was 91%. It didn't change with the update. But we had a few more major responses, under 50%, more than 50% reduction in disease burden. It went from 73 to 78%. And really, this was because we upgraded and got deeper responses. Those VGPRs, where we saw at least, 90% reduction in disease burden, went from 16% to 29%. So the patients that were responding continued to respond, and their response deepened. And we also learned in this trial that, very importantly, the mutation status played a huge role. If you had no MYD88 mutation, this was very well vetted out, you got zeros for major responses. You got some activity. These are called minor responses, but no major responses. And if you had the MYD88 mutation and had no CXCR4, look at these numbers. 97% got a deep response, 44% had a VGPR, and the time to a major response was only 2 months. And when you look at those that had the CXCR4 mutation, look at the decrease, particularly the VGPR difference. 4-fold more VGPRs if you did not have a CXCR4 mutation, but also concerning is the fact that we saw that same lag. It was 6 months on average to get to a deep response. And with the update, though, we did learn something else, and that is that progression, meaning the disease progresses on, could be separated based on that genome. If you had just MYD88 mutation, most of these patients are going strong. Those that had both mutations, the average benefit time was 42 months, which, by the way, is not bad. I mean, 42 months is extraordinary in people that have seen so much prior therapy. And if they had no mutation at all, you see they drop off very quickly. Good news is, take the whole trial together, 5 years, 60% of the patients are projected to be responding. That is outstanding by any measure of any of our prior therapies, so a lot to get excited. And overall therapy was well tolerated. We saw a little bit more hematological toxicity in this population, and we attribute it to the fact that they had seen a lot of prior therapy, and this really affected, the blood stem cells and ability to, be able to have, the ability to make blood cells. And we did see more atrial fibrillation. As time went on, patients, we saw more atrial fibrillation. The rate here is about 11%. Versus 3% with our earlier reporting. Most of these were low grade, and I'm going to say in almost all cases medically managed. How we medically manage we can certainly talk about during our Q&A period, but we can either use drugs to suppress the atrial fibrillation. We can sometimes do cardiac ablation, which is a procedure they do to actually cauterize the tracts that are responsible for the arrhythmia. And sometimes we just put an anticoagulant on board. We give patients a blood thinner, and we're able to manage them. But across the board, whether it's Waldenstrom's or CLL, where the drug is also used very, very heavily, very few times do we ever take people off of drug because of atrial fibrillation. We're also very keen now to make sure the patient doesn't have amyloid. We found a couple of people with heart amyloid. That's a protein that's made, as you heard from Dr. Merlini, by the Waldenstrom cells that can get into the heart. And we found in a couple of cases, even though we suspected ibrutinib, it turned out to be the amyloid. Now, what all this data, the preclinical data, the laboratory data, and the initial clinical data got us was a meeting with the FDA. This was in November of 2012. It was a cold March day. And what came out of this, and I want to show you this because this is when you can put science and clinical data together, what you get is a breakthrough. And a breakthrough designation by the FDA means you're on fast track because you have very credible scientific and clinical evidence that your drug is going to work. And I got to say, this happened on February 12th, which is a special day for both Abe Lincoln as well as myself. It was my birthday, and I thought, what a great birthday present. And so, in a very short period of time, we went on and were able to get the first approval of a drug for Waldenstrom's that came by the FDA, the EMA in Europe, as well as now over 80 countries. And I'm just going to show you here the picture. This is a much sunnier day. It's June of 2014. And these were all the folks that went to the FDA with all this data, and including my friend and colleague here, Leah Palumba, and also all our colleagues at Janssen as well as Pharmacyclics. And I think this was really a great team just coming together, focused on this objective of getting the first drug ever approved for Waldenstrom's. And I just want to conclude here by just showing you all the folks that helped make all this progress possible. Leah, Ranjana, as well as Thorsten Graf at Pharmacyclics, as well as all the funders. And in particular, I want to thank the IWMF as well as the Leukemia Lymphoma Society that really fueled the research that made these discoveries possible. And with that, I'll conclude, and thank you so much for your kind attention. And now I'm going to hand things over to Thanos, who will be briefing you on the two very important INNOVATE trials. Thanos?
Thank you very much, Steve. First of all, I would like to thank Steve for the kind invitation and the opportunity of being here today. And being quite older than Steve, my journey with Waldenström's started in 1990 when I was at the MD Anderson working with Dr. Alexenian. And at that time, we were happy to launch the first phase 2 study for Waldenström's by using a very new agent at that time, a nucleoside analog to chloroxideoxyadenosine, which showed a significant activity in this disease in the context of the first phase 2 study designated for Waldenström's. However, since then, several new treatments have been developed. And in this session, we're talking about BTK inhibitors and more specifically ibrutinib. And based on the work that Steve's lab did and the initial study, ibrutinib was approved for the treatment of patients with this disease. In parallel, within the context of European Consortium for Waldenström's macroglobulinemia, and in collaboration with Pharmacyclics, we initiated the INNOVATE study. This study had 3 arms. One arm, the arm C, was a single-arm study which focused exclusively in patients who were pretreated and rituximab refractory. The original study that Steve published included pretreated patients, but not all of them were resistant to rituximab. So we wanted to have a clean, quote-unquote, population of patients who had failed rituximab beyond any doubt. So these were 36 patients that received ibrutinib as a single agent. And these data were based, of course, on the previous experience that Steve has reported. So in our study, you can see that all patients were rituximab resistant. These are the characteristics of the patients, typical median age for Waldenström's. Many patients had advanced stage, and as you can see, many patients were anemic. Furthermore, at that time also we had realized the importance that several mutations at MYD88 or CXCR4 were important. So you can see here that we had these genotype subsets included in the analysis of the patient. These were heavily pretreated patients, and here is listed the reasons for treatment. Majority of patients had fatigue. Anemia was one of the major causes, enlarged lymph nodes or spleen, peripheral neuropathy, and also significantly elevated levels of serum IgM. These patients had received a median of 4 prior therapies, and you can see the therapies that have been listed here. By definition, all patients were not only pretreated with rituximab, but also were resistant to rituximab. Many patients, almost all patients, had received alkylating agents, namely chlorambucil, corticosteroids. You can see proteasome inhibitors, 1/2 of the patients, immunomodulatory agents, etc. So clearly, this is a heavily pretreated patient population. So what we were able to document is that 71% of the patients responded, including about 1/3 of the patients who achieved a VGPR, meaning more than 90% reduction of the monoclonal protein presentation. Furthermore, there were some patients who achieved a minor response or in whose the disease stabilized while the M protein was increasing. After treatment with ibrutinib, there was a stabilization. Thus, the overall clinical benefit was 87%. An important finding is that the IgM monoclonal protein started to decrease very quickly after the initiation of ibrutinib, but then it took many months to reach the nadir. So this is typical of BTK inhibitor treatment. You have a very brisk decrease of the IgM, but then by continuing therapy, you see that this improvement is ongoing, and this is something which is very gratifying to the patient and the physician. We do not treat IgM. IgM is a marker of disease activity. However, whenever we see that hemoglobin is improving, this is a very good sign because it is associated with the well-being of the patient. And thus, you can see that with treatment with ibrutinib, you have a brisk improvement of hemoglobin. Many patients came off transfusions or came off erythropoietin in this trial. And this was associated also with an improvement of the quality of life of the patient, because whenever you have a treatment that does not have significant toxicities and is associated with response, with improvement of hemoglobin, with reduction of lymphadenopathy, with resolution of B symptoms, this is a treatment that improves the quality of the life of the patient. Regarding the effect of MYD88 and CXCR4 mutations, in this small cohort of patients, it was not possible to draw firm conclusions. However, we saw that all patients responded. However, patients who had CXCR4 mutations and MYD88 wild type tend to respond to a lesser degree and to have a slower response rate. And also the duration of the response was shorter, as you can appreciate here, with a small number of patients. However, with a long median follow-up of approximately 4 years, you can see that the median has not been reached, and this confirmed the previous experience reported by the Dana-Farber group that the majority of the patients treated with ibrutinib respond, and the responses are long-lasting. So this is a unique feature of these BTK inhibitors. And of course, overall survival is completely mature, because in this particular disease, even after failure to ibrutinib, there are other treatment options that patients may enjoy, and thus the overall survival may not be as affected. As far as side effects are concerned, I think that Stephen mentioned the issue with the atrial fibrillation. We have to keep in mind that Waldenström's patients tend to be older. Atrial fibrillation increases with age. It is a complication that can be controlled. In our center, we do not discontinue treatment when a patient develops atrial fibrillation. We try to optimize medical therapy, perform even cardioversion, and try to keep the patient on this treatment because we know that it will benefit him. As far as hypertension is concerned, is a well-known complication of ibrutinib and other BTK inhibitors that can be very well controlled by optimizing the blood pressure drugs. In our experience, the incidence of low blood counts and low platelet is very low, and it has not been a problem with the treatment with ibrutinib. And indeed, the reason for discontinuation of treatment was progressive disease. Of course, when a treatment ceases to benefit the patient, you have to stop and decide about another treatment. However, very few patients discontinue ibrutinib because of side effects, indicating that this is a very safe and effective drug for the treatment. In this particular subset of patients, which I repeat, all were considered to be refractory to rituximab. So this is the most difficult patient population of Waldenström's, which showed that 71% of them responded to treatment with ibrutinib. And now I would like to move to what may be considered one of the most important trials ever conducted in Waldenström's macroglobulinemia. because this is a prospective, randomized, placebo-controlled trial, and actually it is only the third trial ever conducted in Waldenström's randomized trial. And what it is unique about this trial is that it was conducted and reported during a period that it is also clinically relevant. Véronique Leblanc, British colleagues, many years ago conducted a trial comparing chlorambucil to fludarabine, but for this trial it took so many years to accrue the patients and to read out, and at the time of the analysis, unfortunately, these drugs were not very relevant. We're very happy that within the collaboration of the European Consortium for Waldenström's macroglobulinemia and with the collaboration of Pharmacyclics, we were able to complete the accrual of this trial in a timely fashion and to report data that are very clinically relevant in the everyday management of our patients. So in this particular trial, 150 patients were randomized to receive either rituximab and placebo or rituximab and ibrutinib. We have been asked several times why we chose rituximab as a control arm, and the answer is that at the time of trial design, ibrutinib was not approved for the treatment of Waldenström's. The other answer is that still single-agent rituximab is one of the standard of cares, especially in the United States, in patients treated outside centers of excellence or academic departments. So it is an accepted and an active treatment for Waldenström's macroglobulinemia. Furthermore, rituximab was given in an extended fashion, meaning that we gave 4 weeks of rituximab followed by a break and another 4 weeks of rituximab, so 8 administrations of rituximab in total. The other important point of the study is that it is placebo-controlled, and thus it gives you a very accurate assessment regarding toxicities and also regarding PFS. So it is an important trial. Patients were treated until disease progression, and because we wanted to give the opportunity to all patients to receive ibrutinib, there was a crossover, meaning that for patients who were randomized to receive rituximab and placebo, if the disease progressed, they were allowed to receive single-agent ibrutinib. So this trial, at the end of the day, gave the opportunity to all patients to receive ibrutinib free of charge. These are the characteristics of the patients, again, typical of Waldenström's. 1/2 of the patients had advanced stage. Most of the patients were anemic. Many patients had lymph node enlargement or splenomegaly, and almost 1/2 were previously untreated. So this is probably the largest study that included in a prospective fashion previously untreated, newly diagnosed symptomatic patients with Waldenström's macroglobulinemia. 93% of the patients in the ibrutinib and rituximab arm completed their treatment versus 71% on the placebo and rituximab arm. And you can see that the major reason for discontinuation of treatment was progressive disease, which of course was much more common in the rituximab placebo arm. Side effects which led to discontinuation of the treatments were very low in both arms. And this is the main endpoint of the study, and it is probably one of the most impressive progression-free survivals that have been ever reported, not only in Waldenström's, but overall in oncology. You can see that the hazard ratio is 0.2, meaning that there is an 80% probability to reduce progression or death for the patients when they were randomized to receive ibrutinib and rituximab. Furthermore, you can appreciate that even with single-agent rituximab, the median PFS was 20 months, indicating that this is a pretty active drug, especially when given as an extended fashion. We're very happy to observe that the combination of ibrutinib and rituximab was outperforming the control arm in all subset of patients that were analyzed. And of course, it was our particular interest to see what would be the effect of the combination in patients with genotypes that have been previously reported with single-agent ibrutinib to have a less impressive response. And these are patients with MYD88 wild type and CXCR4 mutations. So we saw that even in these patients, we had a similar good outcome. As far as treatment-naive patients, meaning patients who received this combination as first-line treatment, you can appreciate that there is also a significant difference. Of course, keep in mind that the inclusion of patients who were treatment-naive started about a year later from the initiation of the study, so there is a shorter follow-up. And these are patients who were previously treated. You can see that, again, there is a dramatic improvement of the PFS in favor of ibrutinib and rituximab. As far as responses are concerned, again, this is a busy slide, but the bottom line is that the combination of ibrutinib and rituximab induces responses in almost all patients, over 90%, and these responses are essentially equally distributed among different genotypes. So if you take the hard-to-treat MYD88 wild type, you can see responses of 80%, and also you can see a VGPR rate of 18%. So it seems that when you add rituximab to ibrutinib, you can abrogate to a significant extent the adverse impact of a subset of genotypes that were known before not to fare as well to single-agent ibrutinib. Another important point is the very brisk reduction of IgM. We know that with single-agent rituximab, we have the IgM flare. Sometimes we need to prevent this by freezing the patient. By adding ibrutinib to rituximab, this was not anymore a problem. So there was no need for any plasma exchange. We also know that with rituximab, sometimes we have infusion-related reactions. By adding ibrutinib to rituximab, this was not the case. We didn't see any infusion-related reactions to rituximab. And of course, one of the most clinically relevant endpoints is the improvement of the hemoglobin of the patient. And you can see here that an increase of the hemoglobin to more than 11 occurred in almost all patients, indicating that ibrutinib not only decreased IgM, but also led to a very rapid improvement of the hemoglobin. Progression-free survival curves, these are busy curves. The bottom line is that the time that the disease remained in control, what we call progression-free survival, was excellent and did not differ between patients who had the different genotypes and also did not correlate with the depth of the response. Survival analysis, of course, is very premature. It's going to take many, many years to see whether there is a survival difference. However, it is very gratifying to see that in all patients, the survival outcome is excellent. As far as complications are concerned, I mentioned already the abrogation of the flare phenomenon, the abrogation of the infusion reaction phenomenon. We had the usual hypertension, which we see when patients are receiving ibrutinib, and this is something that we need to monitor and to treat appropriately. We had some cases of atrial fibrillation. I would like to remind you that these are elderly persons, and fibrillation, atrial fibrillation is increasing with age. And again, as we mentioned earlier, this is something that can be appropriately diagnosed and treated. Interestingly, it appears that the atrial fibrillation, at least in these studies, occurred relatively early in the course of the disease. And we have seen very few cases of atrial fibrillation developing 3 or 4 years after the administration of ibrutinib. Otherwise, gastrointestinal toxicity, skin rash, weakness, all these were minor and very well dealt with. The patients were so gratified that their disease was controlled that they really wanted to keep up on the treatment. As far as major hemorrhages, again, many of these patients were taking anticoagulation, antiplatelet medicine for other conditions, so there were some bleeding events not really related to ibrutinib, equally distributed in the two arms. And as Steve mentioned, our policy for patients who need to undergo surgery is to try to hold ibrutinib before and after the procedure, and the duration that the patient remains off ibrutinib depends on the invasiveness of the procedure. Usually we try to keep the patients on treatment without drug interruptions as long as possible. Thus, this paper, which was published in New England Journal of Medicine, led very rapidly to the approval by FDA of the combination of ibrutinib in combination with rituximab for patients with previously treated or newly diagnosed symptomatic patients with Waldenstrom's, based on an excellent safety profile and a very interesting data on response and PFS. This year at ASH, my colleague Dr. Busk, who is a co-PI in the study and co-chairman with me of the European Consortium on Waldenstrom's macroglobulinemia, will present an update of this INNOVATE trial. Of course, as you understand, it will require many years to see whether we will see differences in the overall survival of the patient. And with that, I would like to thank all of you for being here today, and of course all colleagues and patients who participated in this endeavor in order to improve treatment outcomes for patients with Waldenstrom's macroglobulinemia. Thank you.
So we have, a luxurious 30 minutes of question and answer period, because we figured perhaps this might be one of the sessions that we have a little bit of time that we need to just talk. And before perhaps any of the questions come up, these are some of the questions that we were left with from the workshop, and it'll be very interesting to have this opportunity with Dr. Demopoulos here to kind of reflect on some of these questions. So perhaps the one that we get asked the most often is, do we really need Rituxan along with ibrutinib? This is probably the most important question. And the other question that we also are facing more and more these days is, how does ibrutinib and Rituxan fit in a world where we have other combination therapies like bendamustine, Rituxan, we have also bortezomib-based therapies. And so it'll be very interesting to just reflect on this particular question. And then, are there other ways that we can help improve the outcome with ibrutinib besides just adding in rituximab? And just so you know, traditionally that's what we've always done. No matter what drug we have, the answer always used to be add Rituxan. And I think almost in every case, Rituxan improved everything. So it was a very logical step to look at this in the context of the INNOVATE trial. Yeah. So we're open for questions, and please, yes.
We don't get this opportunity often, to have the United States and Europe here together. I'm from the Netherlands, I'm Winnie, and I heard the European doctors speak, and I heard Steve speak on the really superb results that you have reached with ibrutinib so far. Only what we have in the Netherlands and in Europe is that ibrutinib as a medicine is still not available in first line. So I would like to ask perhaps the European colleague if he could tell us a little bit more about the timeline before that becomes available. And I heard you mention that the FDA approved not long ago the combination. And if you can give us an idea of how this process will continue in Europe.
Yeah.
Thank you very much.
Yeah, that's an important point because patients hear exciting results and then they get despair because they're not readily available. But I think in this disease we have to decide, and we discussed it yesterday, that there are two treatment philosophies. One is the fixed duration treatment, meaning that the patient will get 6 months of treatment, and then he will be off any therapy, off close observations, off any worries for many months or even years. And this is something that can be achieved today with combinations such as dexamethasone, rituximab, cyclophosphamide, bortezomib, rituximab, with bendamustine, rituximab. So there are combinations that can give to the patient an excellent response, excellent quality of life, off therapy for many months. And there is the other approach, which is based on the unique features of BTK inhibitors, because these drugs are very active, very effective, well tolerated, but they have to be given continuously. So I think that one has to balance one approach versus the other, and in the frontline setting, there is by no means a better way to go one way or the other. So it doesn't mean that if we cannot give tomorrow ibrutinib and rituximab, in Europe our patients will fare worse than patients in the United States where they can get this medication. So on the other hand, EMEA, as you know, takes always more time, and there is a consortium of many countries that go through approval and then reimbursement. So it is expected that this will take some more time, and probably with price negotiation, different prices in different countries. But today, I don't think that this good news, which establish one of the new standard of care, should give any kind of melancholy to European patients who have many, many treatment options today and also in the future.
Okay. Can I just add something to that? There are patients that do not want chemo in their body. And I believe it's high time that in Europe also patients get that choice. Absolutely. Since it is available, and it's been FDA approved since 2015, and we're almost now in 2019. Normally, the FDA approval comes, and it takes only some months before the EMA approves something. We would like to understand why it's taking 4 years, and I would ask the doctors to help us in Europe to get the choice available for patients.
Already single agent ibrutinib, it is approved in Europe and reimbursed for patients who fail chemotherapy, or who fail chemotherapy or are considered not eligible for chemotherapy, which sometimes may be tricky.
Okay.
However, I mean, bortezomib rituximab is a regimen that is chemotherapy-free, that can be also used.
Yeah, no, I completely agree with the person who asked the question, that this is a big concern. And I also don't want to leave the impression that looking at bendamustine, Rituxan, or cyclophosphamide, dexamethasone, Rituxan, these are effective regimens, but for the younger patients, and what is younger these days is anybody that's younger than the oncologist. So I think everyone in this room qualifies. You know, there is this concern about, long-term impact of these drugs. And I think it's becoming a bigger concern as patients are living longer with their disease, and we don't want to really impart another problem. And so having this option, I think, is very important. I think the point about bortezomib is a good one because that also gives you, a perhaps safer therapeutic approach. But having this option available to you up front is important. Now, I have a question for you, Thanos, because when the FDA approved ibrutinib here in the United States, it was for both frontline patients who had not seen therapy, as well as those that had seen therapy. And in Europe, you have this very interesting frontline limitation. It says that you can use it for people that are chemoimmunotherapy ineligible. But that could be somebody who's older and you don't want to put the burden of an alkylator. It could be somebody younger who you don't want to put the burden of an alkylator. I just wonder how European doctors are thinking about this very interesting caveat.
Yeah, it is a problem. On the other hand, I wouldn't recommend, for example, to all my patients ibrutinib. For example, we had a discussion with a 50-year-old gentleman who needed treatment, who could get ibrutinib and with rituximab. And, after a long discussion, he decided that he does not want to start a treatment that will put him, without any interval for 20 years, 30 years. And he elected to receive a 6-month regimen with bortezomib and rituximab, and then have a 4-year, maybe, treatment-free interval. So, these are patient preferences depending on the job, the psychology. There are some patients that see their disease as another project. There are patients who are devastated by their disease, and they focus on that all the time. I think that with this data, EMEA will eventually provide a clearer approval to previously treated and previously untreated patients.
Can I comment on that? So
I have a question.
let me just to complete this. In the 4 years it's been approved, I think I gave it in first line twice. So the fact that it is available doesn't mean that we want to use it for the reason that Dr. Dimopoulos just said. Because if a patient is younger, but up to 70 is still a young patient to me, why would I put them on something that I can never stop to start with, when I know that there are regimens that can give that same patient a very long time without needing treatment, for being treated for only 4 months.
I think on this point, one has to recognize that patient preferences play a very important role. But there are also patients who will come and say, I don't want to be exposed to chemotherapy, and if I can be managed like this and not have any consequences, that they're willing to do this. And of course, we have the paradigm, people on high blood pressure medications, cholesterol controlling medications, diabetes.
They're a little cheaper, though.
And they're a little cheaper, he reminds me. But I think still in the context that, when we trained, both of us, we were internal medicine doctors first, making those prescriptions before we became oncologists. And oncology is really, the mentality really has always been about giving, fixed duration therapy, 6 cycles, 8 cycles, and then watching the patient until they relapse. And so you have to understand that there is going to be differences in philosophies, but also the patients are important participants in those decisions. Okay. I think that gentleman there had a question first. And we'll
My question has to do with the antiplatelet effects of ibrutinib. It's only a question of time when somebody who is doing well on ibrutinib is going to need emergency operation after an accident, where that problem will be overcome by infusion of platelets.
I think that's a good point. If somebody, needs a major surgery because of an accident, I think it's important to have platelet donors donate platelets that won't have the effect of ibrutinib. So platelets that will aggregate appropriately. So that's a good point, and maybe we need to incorporate in our recommendations. To have this option. Yeah.
And
Thank
similar question, suppose you have somebody who's in atrial fibrillation and ablation is not an option. Isn't ibrutinib an adequate anticoagulant?
No. You need to have additional anticoagulation. So if you are in AFib, let's say you take amiodarone or something else to control your rhythm, but you remain in AFib, you need to have appropriate anticoagulation. Yeah.
Thank you.
Yeah, several related questions. First, could you tell us briefly what's known so far about resistance to ibrutinib? That's the first question. The second question is, there used to be talk about other signaling pathways like PI3K and AKT and mTOR. What's the status of drugs for those? And if someone evidenced resistance to ibrutinib, would they be considered as alternatives?
Yeah, I think we'll have Dr. Trion get to all these ibrutinib questions, resistance questions, which are very important, and they are becoming very pertinent because now we have patients 4 or 5 years on ibrutinib, and we start seeing escape mechanisms. But also going back to the other question about continuous versus fixed duration treatment, Dr. Trion's group is initiating a very interesting trial which will combine ibrutinib with venetoclax, so 2 oral non-chemotherapy agents that will be given for a fixed duration of time. So our goal is, of course, to keep the disease under control, but we may be able to do so by giving to the patient treatment-free holidays as well.
And just to answer your question about ibrutinib resistance, this was a very important topic that was discussed at the workshop. And what we are seeing now is that patients who are progressing on ibrutinib do so because they've had a mutation in the site where the ibrutinib binds to the Bruton's tyrosine kinase enzyme. And so this is known as the cysteine 481 position, and it's the same position that you would see a drug like acalabrutinib or zanubrutinib, the other BTK inhibitors that are being developed, bind to. There is, of course, this other drug, which is a Sunesis 62 compound, is what it's called, that binds to an alternative site, and there's work now being done to see if this could be used. Beyond that, we're excited about other opportunities to treat patients with alternative agents. Dr. Castillo presented very nice data on the venetoclax drug, showing in fact that you could induce remissions in patients who progress on ibrutinib. So these are the kind of trials that I think are going to be informative. You also talked about PI3 kinase and mTOR inhibitors.
AKT, yeah.
We've had a lot of experience with these drugs, with everolimus, for instance, showing in fact that they're active but also very, very toxic. So I think we need to keep that in mind. And the PI3K inhibitor idelalisib was also looked after by Dr. Castillo, and that trial was closed early because we saw a lot of hepatotoxicity.
I had some myself.
So this this pathway, though druggable, has its limitations.
Okay, thank you.
Good morning. I'm a caregiver for a loved one who has Bing-Neill syndrome, and I was hoping you could speak to Bing-Neill syndrome, and I was hoping you could speak to the ibrutinib's effect of crossing the blood-brain barrier. Thank you.
Yeah, I think again, Dr. Castillo put together a series of patients treated with ibrutinib. We have some limited experience with 2 patients, and I think that clearly this is the way to go. Maybe if the patient presents with very dramatic effects, maybe you want to start with a short course of systemic intrathecal methotrexate and then move to ibrutinib depending on the condition of the patient. But most of the patients will get a great benefit. It crosses the blood-brain barrier.
Yeah, and I just want to add to that that it is a very effective drug. You know, in the old days, we used to do high-dose methotrexate and other systemic therapies, and I have to say, toxic with limited efficacy. Maybe about 40% of the patients had some benefit. Almost always we ended up having trouble, especially with high-dose methotrexate, and that was the standard. It was one of the drugs that I helped in its development as a standard, you know, way back in my early fellow days. And I think you had also quite a bit of experience at MD Anderson. But ibrutinib does get through. Only about 3% of the drug that's in circulation actually is found in the cerebral spinal fluid, but the levels are high enough that it can actually shut down the critical enzymes, the BTK and HCK, but you have to use a higher dose. You can't do the 420. You know, you got to really start at 560. There have been some patients that have responded at the 420, but 560, which is the dose they use in mantle cell lymphoma, is the dose that we start patients off with. And I have to say, we've been really, really, really pleased with the results that we've had with this higher dose ibrutinib in Bing-Neill syndrome.
Yes.
Have you seen any association of ibrutinib with depression or anxiety?
Yeah, I think, first of all, it's difficult sometimes to differentiate depression due to the disease, to the treatment, to the need to get treatment from a particular drug. But I believe that in this placebo-controlled trial that we had, there was no real difference between, you know, our trial gave the opportunity, being placebo-controlled, to have, you know, a real idea about differences. There was no significant difference between anxiety and depression between the ibrutinib and the control arm.
Is there, going back again to the holding of ibrutinib, is there any specificity or definition or something like which procedures are we talking about, which kind of delays of, you know, 3 days, 5 days, a week, is anything? And in addition, obviously because of the bleeding, we're talking about bleeding issue, but also, is there any other reason or benefit to hold the ibrutinib? For instance, you're getting an immunization or something, and is there anything?
Well, as Steve mentioned earlier, you know, it has to do with the invasiveness of the procedure. If the patient has to undergo triple bypass surgery, definitely he needs at least 1 week before, 1 week after. If the patient has to do a cystoscopy to remove a superficial blood tumor, you may be well off 2 days before and 2 days after. So the risk of bleeding and the duration of the procedure, etc. Colonoscopy, it's much easier.
For colonoscopy, you wouldn't even stop anticoagulation.
Well, you
Well,
might.
it depends if you decide that you have a...
Yeah, if you have a polyp that needs to be removed, it's always better to just pre-anticipate that you might have to.
Yeah, but usually the current guidelines actually, and I'm a gastroenterologist, so I know this, are not even to stop the anticoagulation unless you find something that in your judgment, then you just redo it again.
Okay.
So, because most of them don't bleed. And
Yeah, hematologists are a little bit more cautious.
No. And also, you see, the point is that it's different if you have a patient who has been 2.5 years on ibrutinib, he has an IgM which is 165, and then, you know, he needs to have a surgery and interrupt for a week or 10 days, and different if this happens, you know, when the patient is in the 3rd month of treatment with high IgM levels. And I think that, Steve, you have a lot of experience with this. There is a percentage of patients that even if you discontinue for a week or 10 days, you don't see the IgM rise.
Yeah. Yeah, in fact, that's very true, Thanos. So it's about 37% that will actually have this rebound. And this actually is based on criteria, though. So if you have a 25% increase in IgM with at least 500 milligrams per deciliter, that fits that definition. But you can have people have some, you know, some fluctuation in the IgM. Yeah.
And regards to, is there any other theoretical or proven benefit to holding it for some other reason, like for vaccination or anything?
No, really, you should not stop ibrutinib unless there is a really good reason. Now, if somebody ends up in the hospital, with a pneumonia, for instance, it probably would be prudent to hold. And there may be drugs that they may need to also give the patient that may interfere with the ibrutinib. It's always important before any new drug is started to make sure that there's no interference with the ibrutinib. Those are just the kind of thought processes that go through our head. But sometimes there are drugs that we do have to start where we would have to hold the ibrutinib. And that usually involves hospitalization. I mean, it has to be something that's actually very, very important.
Okay, thank you.
But no casual holding. I mean, that's really I had one guy, I'm going to just share with you, I love him to pieces, but he decided to take a 2-week vacation, and thought, well, you know what, I might as well, I'm doing well on my ibrutinib, I'm going to just not take it for the next 2 weeks. I'll be on like total vacation, not thinking about even my Waldenstroms. Bad move, because we could never get that patient back into a response, and so
but this is an exception.
Well, no, it's the point about holding.
Yeah.
It's the point about holding drug casually, that sometimes you will lose that response, and so really there has to be a reason for stopping the drug. I think we would both agree to that.
Yes, absolutely.
Yeah. Kees, you sat down there, and I hope we got. Did we get your? You got your mic, right?
But I'm happy for this.
You're okay? Because
wait.
Great. We didn't want to shush you off in any way.
I come back on the European issue. I'm very sorry. I don't want to discuss the content or what doctors want to decide to do together with the patients. Well, I only wanted to say it's high time that it is, in first line, an option. And I've understood from Janssen Cyclus in the Netherlands, they really want to push forward. So I want to also to ask European doctors to just look at it in a wider perspective. If it is available, it is in the guidelines as an option, we as patients will deal with our insurance companies, we will deal with the governments, but doctors should rise above that issue and just say it is an option in some patients, and we can now use it for patients.
No, you're absolutely right. But as you know, things don't work that way in Europe. I mean, it doesn't mean that if we have the ESMO guidelines saying that ibrutinib is recommended for frontline treatment, this is something that automatically you can take it up to your insurance. There is the EMEA, the rapporteur. It depends who will get the dossier. How he will evaluate, whether he will be knowledgeable about Waldenström's, but there are concerted efforts in this condition, in other conditions, to try to speed up the procedures in Europe.
Because it starts with the EMA. There it starts.
Yes.
Yes. And I think, Thanos, really, we owe you, a lot of gratitude, because this Innovate AB study is really the kind of study that the EMA needs to see to be able to make this approval possible. So a round of applause, because this is not an easy study to do. Okay, I don't know who's been waiting the longest, but over here, please.
Is the AFib and hypertension due to the heart being affected, or is it something like atherosclerosis where you're damaging the blood vessels?
I don't think it's atherosclerosis. Maybe it's an off-target effect, don't you think?
Off-target.
Yeah.
Yeah, like we said about ibrutinib, that there are other kinases that can be affected, and at least at this point in time, the feeling is that this might be an off-target effect. Probably one of the TEC kinase family members is affected. Yeah.
Now, another word of caution, of course, is that we have patients on ibrutinib now for 5-6 years, but we don't have patients on 20 years. So, we'll have to close monitor to see things, unexpected things may happen. For example, in myeloma with zoledronic acid and biphosphonates, it took us 15 years to realize that some patients develop osteonecrosis of the jaw. So, I mean, there are things that may occur in the future. So this is why it's important to document and to write down and to report any kind of unusual thing that may occur to see whether there's a pattern.
Yeah. I would just add, I think what Thanos said earlier is also something to keep in mind, that, atrial fibrillation increases with age, and this is, a disease of older people, typically. And so this adds, to the potential, risk. And this is why we see that, with time, I mean, if this was simply that a certain kinase was shut down that is important for the heart, and that's why you get the AFib, well, why don't you get it the first day you start on drug? So there has to be other factors. And we know that as we get older, the predispositions are there, so we have to keep that in mind in all our trials. Sir?
Dr. Trian, you mentioned amyloidosis briefly. Excuse me. Could you expand a little bit about that and the use of ibrutinib?
Yeah, so, in general, our experience, and I think this was also alluded to at the workshop, there's a very nice paper out by Dr. Pica showing, in fact, that ibrutinib has very limited activity in patients with amyloid who have the IgM protein. And that really has been our experience as well. The few patients that we've treated with Waldenstrom's and amyloid, we were able to get their IgM down, but the amyloid still progressed. And that's because the amyloid is really the light chain. You've heard about IgM. IgM is a heavy chain, but with it usually is paired another protein called the light chain. And that's really where the precursor is for the amyloid protein. And, in order to get the amyloid under control, you really have to stomp out that light chain, because otherwise it'll continue to accumulate. And, amyloid is like chewing gum. I don't know if you ever, this happened to me with my kids, do you remember the kids getting chewing gum in their hair and then, not being able to get it out? That's what amyloid is. And usually you have to cut out the hair, or I've learned since then you can use peanut butter, but, I didn't know that. I used to just have to, but that's what amyloid is. It gets in, and it's like chewing gum, you can't get rid of it. And if it slowly and chronically accumulates, it's going to affect organ function. In the case of the heart, as it's spreading, it's affecting those conduction pathways, the electrical signaling pathways, and that's why it can affect the heart. The point was that I made earlier is that when somebody develops atrial fibrillation, down the line on ibrutinib, you have to also think maybe it's amyloid. We've had a couple of such cases. Sir, there in the middle.
Hey, thank you very much for the good work. First question is related to dose reduction. Is there any data along that line?
Is there a what?
Dose reduction.
Of ibrutinib, dose reduction of ibrutinib.
Right. Yes, those are built into I think most of our trials, where you can dose reduce. Usually the way this happens is, depending on the toxicity, you'll hold the drug, see if it goes away, and then you'll start the drug back at the same dose. And if the toxicity comes back and it's significant, then you will hold the drug and restart it once the toxicity is gone at the next lower level. So usually, you start at 420, you go to 280, you go down to 140, because that's how the pills are made, and that's how, we've seen. And I think some rare cases, we've actually even done every other day. It's not what I would, if you look at the pharmacokinetics and the ability to inhibit the enzyme, you'll lose that, by that point in time. But some people, we have managed them because, their toxicity was such that they were able to tolerate the every other day, but not the every day. Again, these are tiny little numbers. I don't want you going away today saying, oh, he said you could take it every other day. That's not what I'm saying. But just keep in mind that that's the dose reduction scheme that sometimes we pursue.
Okay, but in reality, though, if somebody can tolerate the high dose, will there be anything that say, oh, okay, use a lesser dose and you still get the same effect?
You want to stay on the 420, because I'll tell you there's two reasons why you want to do that. One, because that's the dose at which you're going to get the shutdown of BTK, but also other kinases that may be very important to the activity of ibrutinib are also affected by dose. And that is one of the reasons why we think if you can get the 420 in, you should stay on the 420. But we've had experiences, Dr. Castillo has also alluded to this in some of his work, that, you know, we can get people, even at 280 and 140, to have sustained benefit. So it's good to keep the full dose, but if you have to for toxicity reasons, you know, reducing the dose is quite appropriate. And you know, what's your experience with that?
Yeah, I mean, I think if you have to keep the patient on the drug and this requires a dose reduction, you do it. I mean, you don't do it if you don't need it.
Okay.
Yeah.
The next question is about platelet properties. If I have the platelet property within range, even after the ibrutinib intake, does it mean that I don't have to put the dose on hold when I go into surgery?
No, no, no. It has nothing to do with the platelet number.
Okay.
It's function.
It's function. So one may have an even high platelet number, the platelet aggregation is affected by ibrutinib. So you need to hold it before and after surgery for this particular reason.
Okay.
Yeah, you know, there are a lot of drugs, like aspirin is a good example. Aspirin can also affect the function of a platelet, just like ibrutinib does. And so even that, they'll tell you, if you're going to go into major surgery, they want you to hold your aspirin because they don't want to put you at risk for bleeding. So that's the kind of mentality, you know, that surrounds ibrutinib.
Okay. Third is, I don't know why, well, let me put it this way. A small molecule is the term used for ibrutinib. What's the significance of that term?
Small molecule. It means it's a tiny little thing that can actually get in the cell, literally.
Okay.
You know, the molecules that have, I think it's less than 500 is the molecular weight of a formula. These molecules are capable of going through the membrane of a cell, and that's why they use the term small molecule. And I think the cutoff is 500 for a molecular weight.
Okay, so
Yeah.
there is some technical significance to that from a physical standpoint.
The significance is that these molecules are able to actually, you know, go through the cell membrane. And it's a little more complex than that, too, because there are also these things called endosomes, which are compartments within a cell. But at this small, you know, tiny little size, they can, you know, they can make their way through. That's what the word small molecule means.
Thank you.
Yeah, yeah.
Well,
Please.
I am one of those I'm on alternating dose, not alternating days, so I take 280 one day and 420 the next. And that seems to be working and I seem to be stable, so it's a little complicated, you know, especially since they changed how they do it, but it's okay, I'm managing. And it leads me to the question, I know that the IgM normal is like less than 300, and I saw it, and mine's around 800 pretty much consistently now. And a lot of people get very low, but it's not necessarily a goal.
Well, the thing is that there are two ways to measure IgM. One is by using electrophoresis, where the monoclonal IgM is a little peak, and also is quantitative immunoglobulin. So when the range of IgM is between, let's say, 50 and 300, you may still have a small monoclonal spike seen on the electrophoresis. I think that the moment that you have a very low IgM, it's okay. I mean, I don't think that if one has an IgM of 800 and another one has an IgM of 300, there is any kind of difference in the outcome, in the years that you will be controlled. You know, it appears for each patient there is a nadir that can be reached, and then it stays there for many, many months and years.
And I have another question. I had aspergillosis when I was on fludarabine, and my concern going on ibrutinib was that, I understand it, so I might have to stop ibrutinib should it recur? I think it's probably not.
You
going
refer
now,
to
but-
medications which called nucleoside analogs. Actually, I had the first publication for fludarabine in Waldenstrom's in 1992. These were very useful drugs at that time because at that time there was only chlorambucil and fludarabine with or without cyclophosphamide and later rituximab or cladribine were very effective in controlling the disease. But also they are very immunosuppressive drugs. They induce T-cell deficiency to a very remarkable degree. And today it is the consensus that these drugs should be available for patients when in need, but not for front-line, second-line, third-line use. There is no any kind of correlation between your aspergillosis on fludarabine and the risk of exacerbation with ibrutinib.
Thank you.
Yeah, the only concern that I have is when you sometimes add steroids to ibrutinib. There was a trial at the NIH for people with primary CNS lymphoma, and they were actually using ibrutinib at a higher dose because they wanted to make sure it was getting into the brain, but they were also giving high-dose steroids, and they did see aspergillosis. We really have not seen that in the experiences that we've had, because we don't usually use steroids, so that would be just something to keep in the back of our minds.
Yeah, there are no opportunistic infections.
Yeah.
So it probably really was a response to the fludarabine.
Most likely, from what you're describing, yeah.
Hi, you just touched a little bit on the drug interactions with the steroids. Since you're going to be on the ibrutinib for such extended periods of time, you also touched on hospitalizations for pneumonia, other things. Is there a lot of common antibiotics or commonly used medications like steroids for asthma or other respiratory reactions that are going to need to be avoided significantly?
Actually, the good news is that, there really aren't a lot of drugs that interact with ibrutinib, but those that are, can do one or two things. They can either accelerate the metabolism of the ibrutinib, so that actually would mean that the drug levels would go down, or they can do the opposite, inhibit. And in fact, one of the drugs is venetoclax that can actually compete. So this trial that we're going to be doing, combining the two drugs together, we're actually going to use half the dose of the venetoclax that Dr. Castillo was able to achieve in his trial. He was able to get to 800. The trial's going to be 400 because we learned that there could be this competition. So we have to think about this in the context of a lot of common drugs that we use. Antidepressants are in that class, certain hypertensives. There are some fungal agents that we've run into trouble with when we've had to treat fungal infections. So there are things. The most important thing is before I tell you, this, and this is, right, and this, and this is wrong, always check with your practitioner, before you go on a new drug. Just make that, your rule, and don't forget how important that is because there are a lot of drugs that can compete. There are also things that you should also be aware of that you might eat. Like if you're a big fan of grapefruit, that usually ends up interfering along, There are these oranges. Have you heard of the Sevilla oranges? Yeah. So usually it's in marmalade, because you wouldn't want to eat a Sevilla orange otherwise. It's just very bitter, but in marmalade it's good. And also Grand Marnier. I had one patient who really flipped out on me because he did not want to give up his Grand Marnier. So we had to, wean him off of that and introduce him to something else that was safe, but just keep that in mind. We're just going to have to wrap up here because Dr. Demopoulos is on a very, very tight schedule. We are so grateful we've been able to leverage all his time this week here, and we're available. I'll be here. So thank you so much, Thanos. And if I'm right, I think Chris Patterson has promised us lunch now. So we will break until 12:30. We're going to have a nice, delicious lunch right outside. And then Judy Trotman and Jorge Castillo are going to be here to talk to you about all the new agents that we learned about at the workshop.